Good morning all. Myself Dr. Harsha from Associate Consultant from the Fortis Hospital, Bangalore. We did low contrast PCI. Here is a 55-year-old male patient with long history of diabetes mellitus, hypertension, admitted in December 2021 with history of acute inferior wall MI, has underwent primary angioplasty to RCA and planned stage PTCA to LM to LAD and LCX. In first admission, his serum creatinine was 1.6 and had increased to 3.1 milligram on day 3 of angioplasty. So revascularization of left system at that was deferred in that setting and planned revascularization after 6 weeks. After 6 weeks, patient came, creatinine has decreased to 1.79 milligram percent. So planned revascularization with low contrast under IVAS guidance. So in the second setting, we went with the femoral route, the EBU 7 French. In the left system, in the Harevo caudal view, showing distal LM to osteoproximal LAD, long segment stenosis, and mid circumflex to major OM, long segment stenosis was there. And we did LCX IVAS, pull back. Distal area was 3 mm square before this thing, and 1.8 and 2 mm was 2 mm measure was there, and near the proximal LCX it is 3 mm measure was there. So this LCX pullback to show the upper branch OM and distal LCX mouth was clean, it's normal. So what did we? We wired the upper branch of the OM1 and then we took a stent of 2.5 into 32 mm stent after preparing the bed with pre-dilatation with the 2 into 15 mm balloon. So here we have not wired a LAD. So our plan was to keep stent away from the L6 ostium, and we deployed 2.5 into 32 mm. Post deployment, our post IVAS run, distal is 2.25 mm diameter, and then near the ostial circ, near in the proximal circ, it was 2.55 mm. Still more expansion is required at that point. And after then again we did with, as it is a 3 mm vessel, we did post dilation with the 3 mm NC balloon. After that, good result came in the LCX. Then we did LAD IVAS, we wired the LAD. This is just to show superficial calcium and attenuated plaque in the LAD. LAD distal is 2.5 mm vessel, and this is the distal, first one is the distal LM. It is lumen area is 4.9 mm square, and the ostial proximal LM was 11.15 mm square area. Then we took plan was a 2 stents strategy, 2.75 into 38 mm LAD, mid LAD to proximal LAD, and LM to LAD is 3.5 into 18 mm. So after LAD stent deployment and LM to LAD stent deployment, we did IVAS pullback. It was distal LAD is 2.51 mm, and near one ostial LAD was critical stenosis was there. There also it 2.7 mm was there. Post stent deployment, again the only one part where it is area was 5.7 mm square. We again with post dilated with the, because LM to LAD was 4 mm vessel, we took a part, we did 4 into 8 mm and post dilatation in the LM and proximal LAD. This is the final result. It's a 3.5 into 12 and 4 into 8 mm post dilatation. Here the total amount of the contrast used was 25 ml. This time patient's serum creatinine has not much changed. It gone up to 1.91 from a baseline of 1.8. Discharge on day 3. So indication of low contrast IUS is whenever the eGFR is less than 30 ml per minute per meter square and serum creatinine of more than 1.5 with age of more than 75 years with low ejection fraction, in anemia, hypotension or long history of diabetes. Take home messages are contrast induced nephropathy is a common complication after any coronary procedures. Many therapies have been tested to avoid contrast induced nephropathy. The only preventive strategy is to decrease the contrast volume and fluid administration. Many ways to decrease contrast volume like engaging catheter without contrast push, discard the contrast in catheter before injecting vasodilator, use IVAS to assess the lesion length and size of stent. Imaging modalities like IVAS are useful in doing angioplasty with minimal contrast, thereby decreasing the chance of CIN and decreasing the hospital stay.